Okay, we're not going to spend a lot of time on the brain tumors because they're pretty much treated like other tumors anywhere else are. So we look at, are they primary or are they secondary? Primary is certain that's something that originates in the central nervous system. They rarely metastasize when they are primary tumors. However, secondary tumors are a result of a metastasis. So that makes pretty much close sense. There is a chart in Chapter 47 of IGI 47-10 that shows about the difference in the cerebral and the brain stem tumors, and you can look over that. Tumors of the brain account for about 2% of cancer deaths. Usually these are at adults 40 to 60 years old. So in the results, the survival rate is quite low. The cerebral tumors usually will manifest themselves with a headache in the morning, especially in the morning, vomiting, visual changes, hemiparesis, hemiplegia, slow movement, or hyper stuff going on, seizures, aphasia, behavior and personality changes. And the brainstem ones will go more toward hearing loss, facial pain, weakness, dysphagia, decreased gag reflexes, nystagmus, hoarseness, and ataxia. So that's just kind of the down and dirty of it. Now, what are the complications of having a brain tumor? Are certainly that it can cause cerebral edema, absolutely increased intracranial pressure, focal neurogenic or neurological deficits, obstruction of the flow of cerebral spinal fluid, can cause the pituitary to go haywire, and can certainly cause seizure activities and hemorrhages. So even though maybe some of these tumors might be malignant or benign, sometimes it doesn't matter because of the location and it being in your head. And a benign tumor in your belly is one thing; it can be removed, and there's space for it to grow. We have people with 200-pound tumors on Discovery Channel all the time, but when it's in your head, there's just not that room. So that's really significant. Okay, looking at some of the treatment, it's just like everything else. There's radiation, chemo, and doing surgery. So, we're going to, those are our options sometimes. We can diagnose usually using the tools that we're pretty familiar with, CTs, MRIs, may even go in and do a biopsy. So, and what the goal of all this is to decrease the tumor size, certainly, and to improve quality of life. So, and certainly to improve survival time. So, remember I said steroids to decrease inflammation and cerebral edema and tumors, and in traumatic brain injury we use the mannitol to decrease the intracranial edema. So the type of treatment certainly depends on the tumor size and the location and what symptoms the client may be showing also. And certainly, as you know, and we always have to recall, by their general condition. If they're 90 years old and have 10 other giant comorbidities going on, well, that they may take a slower hand at trying to do something with these because of their more general condition or fragile condition. Is it a recurrent tumor? It all makes a difference. Also, we may do an LP, and of course, if an LP we get a cloudy result, we think, hey, there's some bacterial something going on in this. If we get a little bloody back, we think, hey, there may be a bleed going on. So with bacterial, we have an increase in protein and a decrease in glucose and the cloudiness. And we'll also have an increase in leukocytes because they're trying to fight that infection. Viral will have an increase in protein and a normal glucose, and it'll usually be clear, but we will have an elevated amount of lymphocytes. Also, if they do that, if they do an LP, they may also do other blood cultures to see what's going on as well. So, course, we knew, well, I'll move on to that. Okay, here's some of the, I think, hold on. Okay, let me back up there. Okay, so we talked about the brain tumors and what we can do if there is going to be a surgical intervention. They'll do a craniotomy and either remove the parts or do the best that they can. And it certainly depends on the location, because sometimes it might be, right there at the brain stem. It might be near all the blood supply. So it just depends on a whole lot of stuff. Okay, let's see what we got here. Okay, Lordy mercy. Okay. So, just depends on what's involved. Okay. So, we may do burr holes, craniotomy, craniectomy, cranioplasty. Just where we'll go in, we might just go in to relieve pressure. We might go in to take a plate out, part of the skull. They'll keep that in the bone bank, frozen, and then they can put that back at a later time when someone. Usually we use that more when there's like a big injury and a lot of swelling, but if they're expecting that place to swell, they may do that. But anyhow, burr holes they can do in the OR, or they can do sometimes in neurointensive care. Some of you may get the opportunity to see that. It's kind of interesting. And that's just about all we're going to do. I'm not going to go into any of the meds or anything other than what I told you about the mannitol and steroids. Okay, looking at, I better do this in a separate piece. Sorry.